Dear colleagues, this is phacoemulsification of a cataract with grade 4 nuclear sclerosis. Let us observe the surgical steps. This is the main incision on the posterior aspect of the limbus. You can see some blood is oozing out from the lips of this wound. Now this is a side port about 3 clock hours away from the main incision. And now I am going to stain the anterior capsule with trypan blue dye. And here goes the dye. The antechamber is shallow at this moment. This is little bit of adrenaline, and with adrenaline pupil has dilated little more. Now 2% hydroxypropyl methyl cellulose is injected into the anterior chamber. Friends, this is a totally unedited surgery. Now capsulorhexis is to be done. The anticapsule is incised with a 26 gauge bend needle. Now I hold this capsular tag with a Utrata forceps, go anti-clockwise and do a continuous curvilinear capsulorhexis. This is a fairly round rhexis. Size of this rhexis is about 5.5 or 5.75 millimeter. The cataract is quite hard. At this moment it is appearing that it may be soft, but in a very short time we will see that this cataract is quite hard. NS is about grade 4. Now the tip of the phaco handpiece is introduced into the anterior chamber. I am in phaco 2 mode from the very beginning. I am removing some superficial cortical matter. Now you can see the brown tinge of the nucleus, and now you see submarine jaw. Push the nucleus little down. Bury the tip just in front of the main incision. Go through the substance of the nucleus like this, as a submarine moves through water. And now just separate the nucleus into 2 halves. This is a beautiful technique for any cataract with NS grade 3 or more. So the nucleus has been divided into 4 large fragments. Phaco power used in this case is 75%. Flow rate is 45 ml per minute, and vacuum is 450 millimeter of mercury. Each nuclear fragment is being subdivided into smaller pieces and emulsified and removed. This is the other nuclear fragment. This nucleus is brittle and it is getting divided very easily. There is no leathery fibers. So every case is different. Every cataract has its own challenges, has its own appearance, its own consistency. No 2 cataracts are same. Since there is only one side port in this case, I'm going to use a Simcoe cannula. You can use a coaxial IA. See how easily the cortical matter comes. This instrument gives the liberty to the surgeon to be as delicate as possible. Automated instruments doesn't have this kind of fine control. Now see, this is hydroimplantation. AC is formed by PSS and a foldable intraocular lens is implanted in the capsular bag. This patient could not afford a hydrophobic IOL, so a hydrophilic acrylic single piece monofocal intraocular lens has been implanted in the capsular bag. And now corneal stroma on either side of the side port are hydrated and the side port closes. The main incision is constructed in such a way that it doesn't need any hydration. This is the final lavage of the anterior chamber. This is a totally unedited surgery and you have watched each and every step of the surgery. The anterior chamber is formed. All the wounds are checked. A little bit of moxie is applied over the ocular surface and the case is concluded. Thank you very much for your attention. Hope this video will inspire you to record your surgeries, audit your own surgeries, and help you in becoming a great surgeon. Be a surgeon with safe surgical hands and serve your patients with lot of love, respect, compassion, and great surgical competence.